Welcome to dentalxp.com. I'm Dr. Maurice Salama, and today I'm going to be taking you through optical and 3D scanning to treatment plan missing teeth in the posterior right maxilla. You can see on this patient that decay underneath the canine has forced the loss of this segmental bridge. And what we will go ahead and proceed with is to section the bridge mesial to the first molar and to section the bridge off of the decayed canine abutment. Part of the treatment plan will involve not only classical cone beam imaging, this is for materialize and planning of the case, but also utilizing optical scanning of the patient's dental model. This allows us now to accurately plan not only the placement and selection of the implants and sizes, but also the actual restoration itself. So both things are going to be done in order to facilitate immediate functional loading of a segmental bridge. Here you can see the implants placed with the screw access channels directly placed in the areas of the future restorations. This is facilitated through optical scanning of the dental model and then combining that optical scan with the digital information taken from the cone beam image. This allows us to place the implants precisely where the future teeth are going to be with no guesswork. Now, in accordance with advanced technologies, what we like to do is extract the teeth with minimal trauma. And what we're doing here is accessing the root canal space of the canine in order to facilitate atraumatic extraction technique utilizing the Easy Extract system from A-Titan Incorporated. We are going to access the canal very much like a parapost, and we go down to a preliminary depth that you can see the digital markings on the side of the drill. This prepares the root for the reception of an extraction screw. Now, this extraction screw that you see being placed into the root is self-tapping and goes in very similar to how you would be tapping an implant. We slowly drive that screw into place, and then we place the impression tray. The impression tray needs to be placed in line with the horizontal line on the extraction screw to make sure that we have adequate space. You can see the placement of the putty impression to protect the adjacent teeth from any of the forces that are going to be placed upon the extraction screw. As we place down this putty matrix, you can see that little horizontal line is left exposed. This is very important in using this technique because once we place the extraction device, we really need to be able to have that clearance. We slowly now will advance this device. As we turn it, you can see the increase in the force being applied vertically, supported by the putty on the adjacent teeth, and eventually feeling the release of the tooth through the stretching of the periodontal ligament. Here, an extraction of a canine root completely atraumatically with no horizontal forces and no damage to the surrounding alveolar housing. A real atraumatic extraction technique, completely done without any trauma. And this is the kit that is utilized. It's something that I utilize quite readily on fractured teeth in the aesthetic zone. We're now going to go ahead and proceed with utilizing the Ankylose Expertise Kit, utilizing a stereolithographic rendering of the optical scan model, as well as a surgical guide that was fabricated by Materialize. This guide has been fabricated off of two scans that have been combined, the optical scan of the teeth as well as the digital scan of the cone beam image. With precise fitting of a tooth-borne surgical guide, I can now go ahead and utilize a trephine to access the soft tissue. So we're going to remove the soft tissue utilizing tissue punches that were accessed through the surgical guide. I'm using a rondure just simply to remove the soft tissue adhesions that have been left behind to make sure that we completely now have access to the ridge form. This patient has medical complications, does not wish to have any regenerative procedures performed to augment the ridge. They just simply want teeth to replace the failed bridge. I can now utilize this same stent with an optimal fitting of the Expertise drills through the surgical guide holes. And this allows me to take it not only mesiodistally, buccolingually, but also to the precise depth. So each one of these drills has to be accessed through a sleeve that is in precise fit to the surrounding sleeve in the surgical guide. This guide never needs to be removed. The optical scanning allows us to have a precise fit on the adjacent teeth, so this is very stable, does not move, and allows for very, very precise drilling of the osteotomies in all 3 dimensions. To me, this is certainly the future in dentistry, being able to plan the case completely through a combination of optical and digital scanning. We go ahead, you can see the bone being taken out through the trephine. We recognize that the drilling is based upon what we've already treatment planned on the computer. The sleeves fit, and you can see how simple the drilling is in both the extraction site and the previously extracted ridge sites. An ankylose CX implant, microtextured to the top and over the top of the implant, is now going to be utilized. We're going to be utilizing the 3.5 millimeter diameter implants. And the same way that we place the drills, a sleeve is allowed in the expertise kit that precisely places the implant all the way down in 3 dimensions, including a vertical stop, which is extremely important to the final success of the restoration. And that what you're seeing on high magnification is the precision of the placement, not only, as I said before, horizontally, but also vertically and mesiodistally. The second implant now in the area of the first bicuspid is inserted, again, in the edentulous area, previously edentulous span. We place a little bit of water irrigation as we initiate the placement of the implant into the osteotomy site. Little bit of heme and torquing this down into its final position, as well as the area of the extracted canine. Again, you can see going down to then 30 and then 40 and then 45 Newton centimeters. Precise flattening of the top of the placement screw with the top of the surgical guide. This guide is now finally removed, and you can see the temporary that has been fabricated as part of the optical scanning, and you can see that this being placed in the mouth fits perfectly over the areas where the implants have been placed. It fits with the occlusion, the screw access, and these are the carrier assemblies that have never been removed. Now we have a couple of options here. One is to remove the carriers and to place individual abutments that are pre-selected. But in this case, in order to facilitate a screw access channel, we simply utilized the carrier assemblies from the ankylose system. And what you're seeing here is just the back ends of the applicators that are wooden sticks that can fit perfectly into these spaces that will accommodate the access to the screw channels when we reline the temporary restoration. We reline this, and those sticks really form a basis for us to gain access to the screw channel. It's a little trick that I have learned from David Garber, and these can be really sticks that are the back ends of an applicator or a cotton swab. And you can see we take it out before it completely sets. We had placed the lubricant on these wooden sticks, so removal of them towards the end of the setting time of the composite or acrylic resin allows for easy removal of these cotton swab wooden sticks, now leaving us with perfect access to the screw channels. We can now go ahead, and again, a procedure that was predominantly done on a computer, and now we can backfill the remaining spaces outside of the mouth as we have accurate and precise fitting of that temporary restoration to the carrier assemblies. As this is being done out of the mouth, polished and sealed in the laboratory, we're going to go ahead and complete the bone grafting on the buccal aspect of the extraction site in the area of the maxillary left canine. PRGF fluid is utilized, plasma-rich in growth factors, and then PRGF mixed with, in this case, mineralized irradiated bone that is then placed and packed onto the buccal aspect utilizing this bird beak bone packing instrument from Devamed. It's one I happen to like a lot. It's rounded and can fit into smaller areas We place a little bit of the PRGF fluid into that area and a little bit of a fibrin plug to seal off that area. Acts much like a short-term autologous barrier membrane that is obviously impregnated with autologous growth factors. This is now backfilled and then reshaped in the laboratory. You can see the CX precise connection fits onto those carrier assemblies. The final PRGF fibrin being placed after screwing in the temporary restoration the day of surgery. You can see just packing that in with the bird beak bone instrument, lightly packing that in just to seal off the bone graft that is beneath this facial plate on the extraction site area, on the area of the canine. Packing in Teflon into the screw access channels. This just simply protects the screw from overlying filling material. We can either use composite resin or ferment, which is a light cured material. And this Teflon material simply acts as a protection for the screw so that we can easily gain access to it after we seal it. Sealing material is placed. Again, this could be flowable resin or ferment, ferment being a material that's used, or you can use Barricade. In this case, Barricade, which is a periodontal dressing, it's a light cured periodontal dressing, is utilized as it's easy to place, it's inexpensive, and is easy to regain access to this area. You can usually use a wet finger with a little bit of alcohol on the finger and then light cure it in place as you see here. So a procedure really taken through a patient, medically compromised, really just wanted teeth. We obviously have a ridge deficiency buccolingually, but we had enough bone present to place implants immediately, and we had enough stability, all the implants placed beyond 40 Newton centimeters, an immediate temporary restoration, being able to be inserted accurately at the time of extraction. Here you can see the pre-op x-ray with the decayed distal aspect of the canine, immediate post-op with the ankylosing implants in place. And you can see that we took this from the optical scan to the mouth, and this is now at 2 weeks post-op, being able to finalize the treatment from the scan to the plan to the actual three-dimensional rendering of a treatment plan in the mouth. I'd like to thank you for your attention this evening, and I hope that this brings up some attention to this whole idea of optical scanning and mixing it with conventional cone beam imagery to make everyday dentistry that much more efficient and successful for our patients. Thank you again from Dental XP. This is Dr. Maurice Salama.